Let's talk about some interesting articular lesions in the hip area. Remember, when we examine the hip, first of course the history, you have the standard questions, what's your problem, when, where, how can you influence it? Yeah? One little trick, if you would have doubts, is it a hip problem or is it a referred pain from the lumbar spine? Ask your patient what happens when he or she is coughing. If you get pain on coughing, then you have a very nice lumbar dural symptom. Okay? What's the capsular pattern in the hip? According to Cyriax, lateral rotation, adduction, okay. And then medial rotation and abduction more limited than flexion, and flexion more limited than extension. You notice the question mark. There are several research papers questioning that. And yeah, everything is evolution, of course. I talk more about research, of course, during our live seminars we teach worldwide. But during the years we came to the conclusion that yes, indeed, we have to rethink that. We have to adapt that a little bit. And we're going to make it more simple. What is the key factor in a capsular pattern? Medial rotation more limited than flexion. Medial rotation is the first movement which is limited when the patient has a certain degree of arthrosis, so he's going to be the top. Okay, we did hip flexion, hip rotations, don't use too much force, yeah. Passive abduction, yeah. When, for instance, the patient has lateral pain, you squeeze in possibly one or more bursae, yeah? Or with adduction you put traction on iliotibial tract, yeah? Resisted flexion, resisted extension, resisted abduction, adduction, passive extension, bilateral medial rotation. So that's a super test to detect beginning arthrosis, because then visually you immediately see the difference between left and right, and you can also check the end feel. Yeah, one side is going to be a little bit harder than the other side. And then resisted rotations, flexion and extension. So as usual, I refer to the separate film on hip examination. Have a closer look to that. One extra test, flexion and adduction. This is the major positive test if the patient has a psoas bursitis. But about bursitis we have a separate film. Okay, let's imagine there is a capsular pattern, so we think of arthrosis and some other options. If the arthrosis is not too advanced, what do I mean by that? If it's not too much limitation of movement with a bony hard end feel, if that would be the case, forget it, hip replacement. So if it's not too severe, at the beginning you can try to do some capsular stretch treatment. Capsular stretch in flexion direction, in extension direction and in medial rotation direction. Like in the shoulder, capsular stretch is not a pleasure treatment. No pain, no gain. Yeah? Okay. And combine it with mobilization, combine it with exercise. Also here we can find an internal derangement, arthrosis and loose body. So if the loose body is a cartilage fragment, of course you don't see it on X-ray. If you find those things, oh, look at those loose bodies, that's horror. Yeah, of course this should be removed from the joint. But I'm more interested in the loose bodies you don't see, but the loose bodies you hear. Yeah? The history of internal derangement, they have irregular twinges. Twinges where? In the groin, anterior, giving way. Sometimes they lose control, yeah? And perhaps a little bit further radiation in that direction. Yeah? Well, what's the clinical image of an internal derangement? Well, you're going to have a non-capsular pattern. Yeah? Possibly flexion more limited, not anymore the hard end feel of the arthrosis, and lateral rotation, which is negative in the capsular pattern, becomes positive. We have to be honest, sometimes you only hear the loose body, and at the time when the patient presents himself to you, yeah, okay, at this moment I don't have any problem. Yeah. You have the story, but you don't have the image. So that's possible. So again, we're going to manipulate. And again, it's a combination of traction and rotation. Yeah? It looks quite terrible, but don't worry. It is not terrible, and it's certainly not painful for the patient. We have two different options. You rotate in lateral rotation or you rotate in medial rotation. We have a second manipulation technique, but we don't use this one that frequent for the simple reason that the first technique I showed you is mostly so efficient. But okay, watch the films on the techniques a little bit later. Yeah? For instance, if the patient would have osteoporosis, this kind of technique is contraindicated. Yeah? There could also be a loose body in a non-arthrotic joint, but this is not so frequent. Yeah? Okay, the manipulation stays the same, but we have to make a differential diagnosis with a labrum problem, specifically in young adults when there was a certain trauma. And labrum problems in the hip, they seem to be quite different, quite frequent. Yeah? And what do they describe? Pain, locking, catching, instability, giving way, stiffness. That's more or less the same story as an internal derangement. So now I have a little problem. Is this connected with an innocent internal derangement? Or is it connected with a labrum problem? Well, there are some tests in literature. In several films I already told you that in the orthopedic profession there's a kind of overconsumption of tests. Well, we have the same problem over here. That looks nice in theory, but the problem is they are all irrelevant. Yeah? They don't have a good validity, except for one test. The impingement test seems to have a better validity. So we're talking about this test, some flexion, some adduction, some medial rotation, and then provoke quite intensively. Okay. So if this test would be positive, then perhaps it's a good idea to refer the patient for medical imaging, okay, to really confirm the diagnosis. So let's have fun with this manipulation technique.
The patient's pelvis is stabilized by a strap. The therapist stands on the end of the couch, grasps the patient's ankle, and holds his limb in about 80 degrees straight leg raise. With a grip that avoids too much movement in the foot, he uses his body weight for applying traction. He maintains this traction while gradually stepping off the couch backwards. In the meantime, during the flight phase, he performs 3 full rotations, medial or lateral rotation. Grip for medial rotation. The therapist faces medially. His distal hand grasps the lateral malleolus, the proximal hand supports and stabilizes the grip. Grip for lateral rotation. The therapist faces laterally. His distal hand grasps the medial malleolus, the proximal hand supports and stabilizes the grip. The patient's pelvis is stabilized by a strap. For a left hip, the maneuver is as follows. The therapist puts his right foot on the couch. By means of an abduction movement, his thigh is put under the patient's knee. Now, the patient's knee is bent, and the therapist half plantiflexes his foot. He leans sideways to increase the traction component, maintains the knee flexion while reaching the end of rotation. The manipulation consists of a high-velocity, low-amplitude jerk towards rotation, combined with the second half of plantiflexion at his foot. Grip for medial rotation. One hand on the outer part of the knee and one hand medially proximal from the foot. Grip for lateral rotation. One hand on the inner part of the knee and one hand laterally proximal from the foot. Half lying on the couch, the legs slightly spread. Two marks are identified: the anterior superior spine of the ilium and the greater trochanter. A perpendicular line is drawn from the anterior superior spine, a horizontal line 5 cm below the tip of the greater trochanter. The needle is inserted at an angle of 45 degrees at the crosshairs in an upper direction, which is well lateral of the femoral nerve and vessels. One will feel the resistance of the thick capsule of the joint. Once this is traversed, the needle will strike bone close to the neck of the femur, or possibly at its junction with the femoral head. Here, the intra-articular injection is given.
Muscular lesions in this area very often are related to sports lesions, and certainly when you think of adductor, yeah? Well, what do you expect? Your resisted adduction should be painful, and the patient has pain somewhere in the groin or somewhere in this area. No? But you also need a positive palpation. If the palpation of the adductor is negative, then your first idea is perhaps he has a pubis problem and not a contractile problem. So keep that in mind. Yeah? Could also be periostitis. We have two localizations. We can have a lesion at the musculotendinous junction, which can be frictioned, or we have a tenoperiosteal lesion, and here we have the two options, friction or infiltration. So this is the palpation and the friction of the tenoperiosteal localization. So you have to feel adductor and bone at the same time. Or the musculotendinous junction, and this is going to be kind of pinching technique. This is a very intensive technique for the therapist. Yeah? At the beginning, you're going to feel that in your thenar. Yeah? A psoas lesion. Your resisted hip flexion from the basic examination is painful. Yeah. And we are lucky if there is a psoas lesion apparently just over there. And this is a spot we can easily palpate. But you have to visualize that again. Exactly in the corner between the inguinal ligament and the sartorius, in between. Yeah. And how can you palpate that? You ask the patient to lie in the Faber position. Flexion, abduction, external rotation. So, in this position. Yeah. Look at that. What a beautiful sartorius. Yeah? So where are you going to find the psoas? We're going to find the psoas over there. Just under the inguinal ligament, medial to the sartorius, in that corner. Voila. And you're going to friction over there. But this is a sensitive spot. So when we friction over there, you're going to friction with your fingers in a flat position. Yeah? The moment you do too much this, it's not going to be pleasant for the patient. And the patient is also positioned in half lying because, remember the basic rules, a muscle belly, you friction from a shorter position. The rectus, well, let me come back to this image. It could also be a rectus lesion. Then not only resisted hip flexion is painful, but also resisted knee extension. And where do we find the rectus? Lateral to the sartorius, and we're going to friction that part. And therefore, we put the patient in this position, but now you're going to really hook your fingers lateral to the sartorius, and your friction is just going to pull towards you. Make sure you have short fingernails. If your fingernails are too long, you could damage some skin, and that's not the purpose. A sartorius lesion is very, 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 very rare. Yeah? You expect pain on resisted flexion and lateral rotation, but your first idea is going to be a fracture of spina iliaca anterior superior. And then flexion and lateral rotation are not only painful, the resisted test, but also weak. And remember the basics of orthopedic medicine, a resisted test which is painful and weak. One of the first ideas, this is a fracture, okay? Happens with young athletes, it's an avulsion fracture. Yeah? They have sudden pain on activity, running becomes impossible, walking is painful, and they limp. Yeah? So it's an, yeah, it's an image that we may not miss. And then the gluteals. Yeah, gluteus medius and his friends. Yeah. A selective lesion of those structures is very, very, very rare. But on resisted abduction, when you have pain on resisted abduction, your first idea is not gluteus medius. Your first idea is compression on an inert structure, or on pain on resisted extension. That's not going to be a gluteus lesion over there. Huh? But compression on an inert structure. More specifically, bursitis. There are a number of bursae in this area, so exclude bursitis first. How can you do that? Diagnostic infiltration. Yeah? But you're going to see these infiltrations in the chapter on bursitis. And then iliotibial tract, of course, very popular among sports people. Mostly the lesion lies cranial from the greater trochanter, but you have to make a differential diagnosis with a gluteal or a bursitis trochanterica because, yeah, they lie in the same area. Yeah. And sometimes the differential diagnosis is not that easy. If the patient is a sportsman, your first idea is iliotibial tract. If the problem just came from the sky, so to speak, it started spontaneously, your first idea is a bursa. Yeah? But you can do some extra tests. For instance, you can do side flexion. It's going to be painful. But if you cross the leg and then you do a side flexion again, you're going to put more tension on the iliotibial tract. That could be more positive. But when you have doubts, do a test friction on the tractors. Do 5 minutes of diagnostic friction, then repeat the functional test, and then the patient is going to tell you if there's a difference, yes or no. If it's a bursitis, I guarantee you that after 5 minutes of deep friction, nothing changes. Nothing, really. So, work as structured as possible, step by step, and try to analyze those images step by step. It's not an exact science, huh? That's a pity. Yeah? But we work with human beings, and clinical images, they could be variable. So, step by step. But I do that, honestly, I see that once in a while, and I have to do a diagnostic friction massage just to confirm my diagnosis. Yeah? So how do we do that? We do that with the patient inside lying, with a flat thumb. Okay, but it's described in the next films. And then quadriceps and hamstrings, well, a muscle belly lesion of the hamstrings, a real nice muscle belly lesion, what is going to happen? The fibers along that lesion, automatically they go into spasm to protect that lesion. Spasm results in limitation of movement. In another film I talked about the tennis leg, acute muscle belly lesion of the gastrocnemius. You're going to have limitation of passive dorsiflexion because of the spasm. Well, when you have an acute hamstrings lesion, your straight leg raise, for instance, is going to be painful and limited. If you have a tenoperiosteal lesion, you don't have this muscle spasm, you don't have limitation. Yeah? Keep that in mind. Yeah? Okay, when you want to friction and palpate the tenoperiosteal parts, you have contact on hamstrings and ischium at the same time. The side lying position is much easier for you as a therapist in comparison to the patient in supine lying. Really. And then the position for muscle belly friction. So, perhaps it's time for a coffee. Let's have a look at the films.
The starting position, slight abduction and lateral rotation. The deep friction is a pinching technique with thumb and fingers, with the heel of the hand as a fulcrum. A large reserve of skin is taken in a lateral direction, then pressure is applied, and the active phase of the deep friction is a horizontal movement in a medial direction. Make sure the arm stays parallel to the leg. Starting position, slight abduction and lateral rotation. For a right adductor longus, we palpate in the cranial direction with the left middle finger until we feel the inferior edge of the pubic bone. The finger is then turned 45 degrees medially and now feels bone and tendon at the same time. It is reinforced by the other middle finger. The deep friction is executed normally. The muscle is in a fully relaxed position, prone lying, knees 90 degrees flexed. The deep friction is the normal execution with all fingers, covering a large area in order to have an optimal mobilization of all fibers. The active phase of the deep friction is a pressure towards the therapist. The patient lies on his side with the hips and the knees in 90 degrees flexion. The deep friction is executed normally with 2 or 3 fingers. They feel the ischium and the tendons at the same time. It is easier to work in close contact with the patient on a higher position treatment table. The patient adopts the half-lying position. Site of the lesion, below the inguinal ligament and medial to the sartorius muscle. For a right psoas muscle, we use the right index and middle fingers, reinforced by the left middle and ring fingers. For the patient's comfort, it is essential to keep the fingers horizontal and to increase the pressure gradually. Make sure that during the deep friction you keep a deep contact. The patient sits with 90 degrees hip flexion. We find the tendon just lateral to the sartorius muscle. For a right rectus femoris, the flexed fingers of the left hand, reinforced by the fingers of the other hand, grasp the tendon. The deep friction is a normal execution with an active phase towards the therapist. The treatment table is in the lower position. The patient lies on his side with a cushion between his knees. After having localized the lesion, the therapist takes a reserve of skin towards himself, then puts the thumb onto the lesion and reinforces it with the heel of the other hand. Both arms are extended. The deep friction is the normal execution, in which the active phase is a forward movement of the entire trunk. The patient's pelvis is stabilized by the therapist's thigh and fingers. Half-lying on the couch. The affected thigh in slight abduction and lateral rotation. We palpate a painful spot in the origin of the adductor longus tendon. The needle is inserted just below the palpating finger and directed towards the lesion. The entire painful tenoperiosteal origin is infiltrated by a series of small withdrawals and reinsertions at slightly different points, after having felt tendinous resistance and contact with the bone.
Welcome back again. I hope this film gave you some new insight or some basic insight in diagnostic interpretation, in differential diagnosis when it comes to articular lesions and muscular lesions in the hip area. As always, a good basic examination is the start of your success in musculoskeletal medicine. Of course, sometimes we need medical imaging to reach some differential diagnostic option, but first we focus on the basic examination. So if you have any further questions on that specific topic, feel free to use the live chat, and if you're watching this webinar in a replay mode, then use the email function and send me an email. I'm going to be happy to reply you. As usual, during those webinars, the films you see, they are part of the online course in orthopedic medicine, the masterclass in orthopedic medicine. Is a series of 68 films on diagnosis, differential diagnosis, treatment strategy and treatment techniques. So during this webinar you got one lesson for free. Just surf to learnorthopedicmedicine.com and discover what the online course can offer you. And if you use the bonus code webinar to register for the online learning platform, by the way, you can do that also on a monthly basis, then you're going to receive a nice surprise. So that's all from today. So if you have any further questions, feel free to contact me. Thank you very much for joining this webinar, and I look forward to the next one. So bye-bye.